Upon presentation to the La Trobe Health Sciences Clinic, Mr. X reported with no new issues, as he stated all is good. It was our intention to treat the patient in reducing or eliminating all pathologies while providing general nail and foot care. Patient assessment and interviewing is imperative. Contrary to previous patient notes, it was critical that we still identified any new areas of concern and interviewed the patient thoroughly. After thorough interviewing, the patient complied with previous treatment plans and did not present with any new issues. With Mr. X's medical history, living with osteoarthritis in his right hip and both hands, general foot and nail care proves to be difficult. In an effort to keep his osteoarthritis under control, the patient was taking Mobic, an NSAID, an OX2 inhibitor, once daily, and also Panadol Osteo when required. Other medications that the patient reported were Zoloft, a prescribed antidepressant, and also aspirin, which he took once daily as part of a clinical trial. Mr. X presented upon his most recent visit for a review of his onychoxic fifth nail on the left foot and possible onychomycotic nails present on the first and fourth nails bilaterally. Dermatologically, potential presence of tinea pedis in all web spaces of the left foot and maceration in the fourth web space of his right foot. The current vascular status of the retired nail indicated an adequate amount of blood flow, with all pedal pulses palpable and the feet warm with adequate amount of hair and nail growth. Neurologically, there appeared to be no new issues, as the patient was able to identify areas of itchiness and concern upon presentation. Footwear was adequate after the patient complied with previous recommendations, wearing a supportive and well-fitted shoe. The next step of the treatment process was to cut, clear, and file all non-symptomatic nails. When reducing elongated nails, it is important to cut the toenail straight, not round at the edges, as this can cause painful involution and possible infected nail fold, according to DaCosta 2012. The onychoxic nail on the fifth of the left foot was due to trauma suffered when gardening. This etiology was identified whilst undertaking the patient interview, ruling out any neurological concerns. We continued to cut, clear, and burr the onychoxic nail, as this appears to be the most effective treatment option, as it reduces frictional pressures and prevents any further pathologies. Overall, treatment of the onychoxic nail was similar to the other non-symptomatic nails. The suspected onychomycotic nails on the first and fourth digits of both feet were treated in isolation in an effort to prevent spread to other digits. These nails were suspected to have spread fungal elements to the web spaces, which was the possible cause of interdigital tinea pedis. Barron 2012 states that fungal infections destroy superficial layers of the nail and skin, as well as inhibiting keratin production. A possible treatment that we recommended to the patient was use of Canesten spray to prevent the spread and hopefully reduce the severity of the alleged fungal infection. We educated the patient that it is important to use the spray in moderation, as this can create a moist environment, allowing the infection to become more severe and possibly spread, linking closely with his interdigital maceration. In addition to treatment with Canesten, a skin scraping of the affected nail and tissue can help confirm suspicions that the affected nail and skin was onychomycosis and tinea pedis respectively. This would help rule out any other differential diagnoses, including maceration and dermatitis, and prove that the potential diagnosis of fungal nail and tinea pedis. However, as part of our treatment, we did not undertake a tissue scraping, and in future consultations, it could be an option to help confirm diagnosis and proceed with the correct treatment plan. Based on previous SOAP notes, the area of maceration had reduced dramatically as the patient reported using methylated spirits. We advised the patient to continue use of the astringent and dry the web spaces to prevent the reoccurrence of maceration and any further tinea formation. When used in combination with Canesten, the drying agent can help reduce the symptoms for both the maceration and the interdigital tinea pedis. The patient was advised to return in 2 months for a review of mycotic nails, tinea pedis, and for general foot and nail care. Upon review of the treatment plan, there are some treatment options that were undertaken correctly, while other options could be reviewed to produce a more effective treatment outcome. These include taking a tissue scraping combined with potassium hydroxide to undertake a lab test in an effort to confirm the presence of fungal elements. Overall, if diagnoses are accurate, then the treatment plans will meet the needs of the patient, and Mr. X will have a better outlook on his quality of life. Thank you.